Hello, everyone. I'm Ross Dolan. I'm one of the surgeons currently working in Newcastle, and I'm part of the Cachexia Society Educational Committee. And I'm delighted to introduce the latest in our series of educational talks. So I'm just going to have a few shout outs about things that will be happening in the future. I think we all enjoyed ourselves at the seventh Cachexia conference in Edinburgh. I certainly did, and if anyone's looking to repeat that, the eighth conference is going to happen in Turin this year in September 2025. We have some further seminars coming up in December. On the 11th of December, we have an excellent seminar from Alessandro Laviano summarizing a year in cancer cachexia. I've seen similar talks by Alessandro previously, very informative, and I encourage people to attend that if you can. We have a further seminar by Andrea Bonetto coming up as well in January. He works in the Department of Pathology in Colorado, and again, should be a very interesting talk. And finally, it is my pleasure to introduce my friends and colleagues, Professor Barry Laird and Professor Richard Skipworth, who are going to give us a talk tonight on cancer cachexia clinical trial design. It should be very informative, and I'm delighted to hand over to Professor Laird. There you go, Barry. You should be able to load up now.
Thanks, Ross. I'll just give me a second, check it works.
One thing just before we start, if you have any questions, there will be a Q&A session at the end of this. If you could please put them in the chat, that would be fantastic. Thank you.
Ross, does that look okay now?
That looks fine.
Perfect. So thanks very much to the Education Committee for the invitation to speak tonight. We're meant to be a double act with Richard and I, and unfortunately, Richard's got a prior family engagement, so sends his apologies. But both of us have worked on this presentation together, so I'm proud to present this on behalf of the two of us. These are some of the disclosures. And if we go back a bit in time, just to start with this, cachexia was really first described by Hippocrates sort of 460 BC, when he described it as a condition of flesh melting away from the body. And just to put that in some form of context, that's almost 2,500 years ago when this condition was first described. Now, the picture you see on your screen is Old College in Edinburgh. This is the main sort of university sort of ceremonial building, if you like, and it was developed around 200 years ago. And the mountain you can see in the background is Arthur's Seat. It's an extinct volcano. It's not erupted for a long time, and we hope it never will. And some of you, when you're in Edinburgh, may have even climbed this small hill. But around 200 years ago, the same time as this college was built, the hand grip dynamometer was developed, which is something that I'll talk about later on in this presentation, which is something we use to measure physical function in cachexia trials. So you'll see from these sort of three different charts here, one on assessment, one on diagnosis, that a lot has actually happened in the last 200 years. In regards to assessment, we've gone from having a hand grip dynamometer developing, identifying CRP as a biomarker, and that's almost 100 years old. And that's probably the most standardized biomarker anywhere in the world. With almost 50 years since we've had this CT scans done, and we use these now for body composition analysis. And various things have happened in terms of our assessment of cachexia over these years, including, around 2014, this Glasgow prognostic score being identified for measuring inflammation using C-reactive protein and albumin. If we move on then to the sort of diagnosis tree for cancer cachexia, well, the first mention of the term cancerous cachexia in the medical literature was actually written by an ophthalmologist. And then it was a long time afterwards until somebody wrote that cachexia was a skeleton in the hospital closet. Sort of maybe a British phrase, but it means that it's there. It's there hidden away for us. And then if you go through time, you've got guidelines published over the last few years, including some by ASCO and some by ESMO and some by ESPEN. And you've got this obviously seminal diagnosis and assessment classification paper by Ken Fearon and others in 2011. But if you look at the treatment line here, really well, from 1974, when cytokines were first discovered, there's been a few trials and things assessed over this time. And it's this aspect on treatment I'm going to focus on today, but it does also link in with diagnosis and assessment of cachexia. And hopefully throughout this lecture, you'll realise how they're all interlinked. Now, I don't for any way consider myself an expert in cancer cachexia clinical trial design. If anything, the more I work in the field of cancer cachexia clinical trials, the more I think how difficult it is and how many challenges there actually are. But I'm going to give you some of my thoughts today and some experiences that I've had and my collective colleagues have had in this area. So let's just go back in the last 10 years now, looking at different trials that have been done in this field. So I've divided these up into phase 2 trials, phase 3 trials, and non-CTIMP trials. Now, for people who are not terribly familiar with this vernacular, a phase 2 trial is essentially when a drug's been developed and it's shown to be safe, but we want to see if it's got some evidence of efficacy. Does it work? We don't obviously do large-scale trials at this time because they're expensive. We want to get some indication of the drug's efficacy before we launch onto a larger trial. So that would be a phase 3 trial. And then we have what we call non-CTIMP trials. So CTIMP is clinical trial of investigational medicinal product or a drug trial. So phase 2 and phase 3 are typically drug trials, and we have non-CTIMP trials. So actually, there's quite a lot been happening in the last 10 years or so. We've gone from trials of enobosarm, then espindol, anamorelin, trial looking at a MAB-P1, so that's an IL-1 alpha humanized monoclonal antibody. Recently, there's been the olanzapine trial that was published and the SCALA trial, using anamorelin again. And very recently, there's a trial looking at ponsegromab, a GDF15 pathway target, published just in September. And then if you think about some non-CTIMP trials, these just a few that I've mentioned here that I've been part of or I'm aware of, and I'm going to touch on these as we go through. And I'm going to try and use some of these trials to highlight some of the differences between studies, some of the challenges that's been identified in conducting these. So if we go back to the enobosarm trial and say the espindolol trial, so these were both phase 2 clinical trials. So enobosarm was a selective androgen receptor modulator, and ACT1 was an anabolic anticatabolic beta blocker type drug. And these were both double-blind, randomized controlled phase 2 trials with multiple arms, because both of these trials assessed a placebo arm, but also assessed the drug in different doses as well. And they were actually similar sizes in terms of their trials. Now, just looking at these studies for a moment, the first thing you might comment on is, I have not seen the phase 3 trials from these initial phase 2 trials. Now, I know there are things in development for these trials, for example, that I'm not going to say any more about just now, but further news will come in due course with these studies. But in this study, for example, you can even see some differences at this point. So, for example, in the enobosarm trial, they took patients who'd lost at least 2% weight loss, and they took a primary endpoint of change of lean body mass, so muscle. And in terms of endpoints for these trials, we talked about both, objective endpoints, functional endpoints. So you look at how much muscle someone's gained or lost, but also look at how that muscle functions. So in the enobosarm, their main measure of function was a stair climb test, so how quickly it took somebody to climb a flight of stairs. Whereas in the espindolol trial, they looked at just weight as a primary endpoint, but also looked at hand grip strength, so a different measure of function here. Two trials around the same time, similar designs, slightly different populations, and also slightly different endpoints and designs of these studies. Now, we then go on to two quite pivotal phase 3 trials. So the first one was the Anamorelin trials. This was Romana 1 and Romana 2. In general consensus is that at this point you needed two large trials to get approval from drug regulators. So they did essentially two identical trials for the Romana 1 and Romana 2, and similar for the MAB-P1 studies. So this was exciting. This is a very exciting time. This was around 2016, 2017. So the Romana trials, the Anamorelin studies, so a ghrelin agonist trying to improve hunger, took patients with inoperable stage 3 or stage 4 non-small cell lung cancer, and they randomly assigned them to get Anamorelin or a placebo in a 2-to-1 ratio in favour of the Anamorelin arm. In these patients, they had improvements in lean mass, so the amount of muscle they had improved, but there was no difference in hand grip strength. So they met their endpoints in terms of improving muscle, but didn't meet their endpoints in terms of improving function. In the MAB-P1 study, it was a slightly different approach. They took patients with colorectal cancer, so something that we know gets cachexia, but potentially not as prevalent as cachexia and say lung cancer, and they give this monoclonal antibody intravenously by in a 2-to-1 randomization, again in favour of the active drug. But their endpoint was quite different, actually. They looked at the number of patients who had stable or improved weight, but then looked at symptoms as an endpoint, and they had this sort of composite endpoint. Now, these were big studies. They cost a lot of money, and they were then put to regulators to aim to get approval. Around this time, Ken Fearna and others had written this statement of how some guidance was needed from regulators. So that's people like the Food and Drug Administration in the United States, or the European Medicines Agency in Europe, saying that we need some guidance from you as to how we should design trials in such a way that will allow us to get regulatory approval. One of his comments here was that in the field of cachexia, is it just enough that actually people stop losing weight or stop losing muscle function? Whereas prior to that, the aim had been that people had to gain weight or improvements in muscle function. Were these actually, aims that were unachievable? So when these two drugs went to the regulators, they both went to the EMA, the European Medicines Agency. The first one was Anamorelin. They actually both went at the same time. Actually, both went at the same meeting. And I don't know if that was by coincidence or not. So this was a report they suggest. This is a report that the EMA published, and this is publicly available. The company presented results of two main studies around 1,000 patients with cachexia. And they concluded that the studies showed a marginal effect on lean body mass, so minimal improvements in lean body mass. And you can see that here in Romana 1, a difference of just about 1.5 kilograms between the arms. So they call it a marginal improvement, but no effect on hand grip strength or quality of life. So improved mass, but not function. And one of the sort of, dictum we hear is that it's improved patients how they feel, how their form is, or how they function, and it only met one of those. So this was refused. And then, as I say, MAB-P1, this IL-1 alpha antibody went as well, and they had this endpoint, which was a change in lean body mass. So to have a successful primary endpoint, you had an improvement in lean body mass of greater than or equal to 0 kilograms or more, so stable or gain lean mass, and then you had to have improvements in 2 out of 3 symptoms. This was quite a novel endpoint. I certainly haven't seen it before, and I haven't seen it since. But again, they didn't really get this endpoint at all. They felt this was not really helpful, and they didn't feel it was actually significantly improved symptoms in terms of pain, fatigue, or appetite scales. So again, this was not approved by the EMA. So that's two big trials based on a lot of early evidence, cost a lot of money and didn't reach approval. So at that point, you might think, well, things are actually it's quite a depressing state, and how can we take things forward? So what trials have led to regulatory approval? How do we get over this barrier? Well, at the moment, the only drug that's been approved anywhere in the world is anamorilin, and that was approved in Japan in 2020. That was not approved on the basis of these Romana trials that I've talked about earlier. It was approved on the basis of another two trials that were done. You'll see these here, and they showed, for example, the first phase 2 trial on the screen showed improvements of lean body mass of 1.56 kilograms and improvements in anorexia symptoms. They didn't have improvements in hand grip strength or 6-minute walk test. In another phase 2 trial, again, improvements in lean mass, but they didn't assess muscle strength and physical function. But that improvement, certainly from the first of those two trials, was enough for certainly the Japanese health authority to give this a license. At the moment, it's, as I say, the only drug that's been approved in terms of medical regulators. But trials have been endorsed on guidelines. So a good example of this would be a study of olanzapine. There was a randomized, double-blind, placebo-controlled study of olanzapine for chemotherapy-related anorexia, and this was published in the Journal of Clinical Oncology. I think it was last year it was published. They took adults with various cancers and both groups got standard nutritional assessment and dietary advice. And they looked not at the actual sort of raw values, but they looked at the proportion of patients who had weight gain of greater than 5% and improvement in appetite. This was quite a small trial, a 2-arm trial, 124 patients. And they showed that more patients in the treatment arm versus the placebo arm, so the olanzapine arm, had improvements and had weight gain of greater than 5%. And we know that's maybe a clinically significant number, and improvements in sort of assessments of appetite using the FACT score. So based on this, the ASCO guidelines group released this rapid recommendation on using olanzapine to treat cancer cachexia. So they said that we recommend that clinicians offer low-dose olanzapine once daily, secondly, for not patients who can't tolerate that, they might think of other types of steroid-related drugs. So a trial not getting regulatory approval doesn't mean it can't be endorsed on a guideline. In this case, olanzapine wasn't a drug that existed anyway. It didn't need regulatory approval. But endorsement here was done because the drug's available, and had the data here were probably less convincing than they were for, say, the anamorilin trials. So if it had been approved, I would hazard a guess that guidelines might have actually endorsed these drugs. It's simple. There's no point really in endorsing drugs if they're not available. And I'm speculating here, but I suspect that may be one type approach. But it's an interesting paradigm that drugs can be improved on guidelines with quite small trials data, but yet large scale pharmaceutical trials, if they don't get regulatory approval, they don't make onto guidelines for us. So how do we try to best design a clinical trial? Well, I think if we use the oncology setting as an example, they take a mechanistic approach. They find a target and they try and treat that target. So one way of looking at this might be looking at inflammation, for example. So the GLIM criteria talk about cachexia being a chronic disease-related malnutrition, and if inflammation is present, that's cancer cachexia. And whether you agree with that approach or not, that's another matter. But one type of a thing that we can't really deny is that the metabolic change or systemic inflammation is highly implicated in the genesis, the maintenance, and the progression of the cachexia state. So one type of approach that we're advocating is that you can assess the inflammatory state of the patient using a score or other inflammatory measures. And if patients are inflamed and have nutritional risk, then you should maybe target treatment based on that. So considering putting things like inflammatory risk or malnutrition risk high up in the eligibility criteria of clinical trials, we've actually sort of suggested that GLIM need to maybe think about how they change their wording here. We're actually saying it's not really disease-related malnutrition, it's disease-related inflammation, where malnutrition present is we think is probably more cachexia. That's just one way of thinking about it as a mechanistic approach. That's another example of a mechanistic approach, and this is this table here is from the ESPEN guidelines, and they say these are general concepts of treatment relevant to all cancer patients. So they think exercise is good, and that should include oral nutrition and medical nutrition, and exercise is good as well. Now, a hypothesis that we've had and others have had is that cachexia is a complex syndrome with multiple, if you like, pathways and processes that result in it, that to target cachexia optimally, you have to target these different approaches. So exercise, nutrition, and potentially inflammation. So we undertook a study called the pre-MENAC study, and we've also completed the follow-up, which is called the MENAC study, and we're presenting that at the meeting, the SCWD meeting in Washington next month. But this was just an example of a study where we took a mechanistic approach to how we designed it. We thought that if we gave people exercise, nutrition, and anti-inflammatories in combination, that might improve outcomes. So this was our phase 2 study, our feasibility trial, if you like, to see if the trial was feasible, people would do that. And it seemed to be effective in terms of feasibility and have encouraging effects on on meaningful endpoints such as mass and lean mass and also body weight. So as I say, we're going to present this later on in the year at the meeting. But these are just two examples of mechanistic approaches and how you design a cachexia trial. But also, I think this was a paper that was published in the last week or two by Professor Barakos in Alberta. And, I think she makes a point here, there's quite a big leap here between centrally acting mechanisms and peripheral endpoints. So I'll touch on the GDF15 work later on, but olanzapine and GDF15, they target primarily brainstem neuronal pathways, but yet they're measuring end organ effects. So it's quite a big jump from a drug that's going to work in the brain to actually having effects on muscle or fat or even the muscle function. So in these drugs, for example, they improve symptoms by addressing appetite loss, early satiety, nausea, but patients seem to feel better on them, and that patients feel better, they eat more, and we know that if you feel better, you'll eat more, and then that food intake increases their energy expenditure, and that improved muscle function is really needed for regulatory approval, but actually, is restoring muscle function or stopping the loss of muscle function potentially a more realistic outcome. So again, a lot of times in these drugs, we're measuring we're doing a sort of centrally acting effect, but having peripheral measures of that drug's efficacy. So another aspect that comes up in trials is the population. How do we decide which patients go into a study? So again, I'm going to talk about a couple of different examples of this. What you want in a clinical trial is a very clean design. You want a very well defined cohort of people that go into a study, and ideally nothing happens to them apart from that study. There's no other background noise that can affect the influence of that drug. So you might want to do a trial in, say, non-small cell lung cancer, stage 4, with people that are PDL greater than 50%, but also are not getting any treatment, but are also well enough to take part in a clinical trial. And such patients don't exist, or don't exist in enough numbers to do a clinical trial. But also that limits then the ability of pharmaceutical companies to get licenses, because the limits in the license are then quite small. So there's other ways of approaching it. So one example again would be in the Ponsegromab study. They looked at GDF15 as an eligibility criteria, but interestingly, over 90% of patients had a raised GDF15. It's a stress hormone, so maybe it's endemic amongst a lot of our patients, and I think it probably is. In Anamorelin, well, the inflammatory status could have predicted the outcome as well. So work again that we're going to present next month seems to suggest that the inflammatory status and/or the degree of weight loss helped identify optimal responders in these Anamorelin studies. The sort of immunotherapy studies, IL-6s, IL-1s, well, they had a very broad brush approach, saying these cytokines are major players in the cachexia pathways, and if we target them, we can damp down the whole sort of approach. But these generally haven't led to successful trials in terms of safety and have not gone on to phase 3 studies, with the exception of the MAB-P1 study. But also, I think if you look at how systemic anti-cancer therapy works for, say, lung cancer or breast cancer, they're now using targeted therapies. So we can really distill non-small cell lung cancer down into various subtypes, and then treatment is very much directed at that. And maybe that's what we need to do with cancer cachexia. But is there also room for targeted pathways, such as, say, GDF15 or olanzapine or Anamorelin, but also looking at things which might affect overall biological changes? So should we combine, basic cachexia care, such as exercise, nutrition, alongside these targeted therapies, based on their cachexia phenotype? So lots to think about. In terms of the patient population, well, almost all the studies that have been done thus far have been in lung, colorectal cancer, or pancreatic cancer. Our feeling is that these are cancers where cachexia is common, so that's where we should try and treat them. But yeah, are we neglecting other groups? Should we think about looking at cachexia in, say, breast cancer and metastatic breast cancer? Another challenge we've got is the changing systemic cancer therapy landscape. When we started our MENAC trial, immunotherapy for lung cancer didn't happen. As we went through our trial, it became the mainstay of treatment. And we know that these therapies are likely to impact on outcomes in our trial, such as lean mass. So this background noise of systemic therapies is very difficult to disentangle. I guess, should we put in patients who have lost weight, or should we put in patients where weight loss is predicted to happen? Again, in some of the studies I've mentioned, they've looked at patients who have lost 5% or more of body weight. In our MENAC trial, we said, well, these are people who are going to lose weight. So irrespective of whether or not they've lost weight or not, we're going to try to give it to these people. This is where we see it sitting in the clinical setting. But yeah, should we think about whether we need to prevent weight loss, maintain their weight, or improve weight? And that's also very difficult. When do we give patients these clinical trials? Ideally, you want it when they're well enough to last the duration of a clinical trial. So we do it when they're newly diagnosed. Potentially, but on the other hand, that's a very difficult time for people. There's a lot of information overload. And I know from my experience with clinical trials, that's been a reason for people declining taking part in trials. We've also got the challenge that concurrent clinical trials are really not permitted. So if somebody's on a cancer therapy trial, they're not really allowed to take part in a cachexia trial. Is that something we need to challenge, have a think about, and improve in the future? And I wonder, really, when you're thinking about your eligibility criteria, that really needs to relate to your endpoint. So if you're going to measure, for example, weight loss, or sorry, weight change as an endpoint, you really need to have some form of weight, eligibility criteria to give yourselves the best chance of succeeding. So then I'll talk about a bit about the duration of intervention. So here's some examples. I talked about our MENAC study again. We did that for 6 weeks because we thought that giving people, doing the intervention longer than that would result in a high degree of attrition. So that was what we thought. The Anamorelin trials, they did over 12 weeks, and that seems to be more of the norm in the cachexia field, doing trials over sort of a 12-week period. And I think that's because overall survival's improved in lung cancer now, and patients are living longer to take part in these trials. But yeah, another study that's been done, this was by Cachexia and others, It showed that actually we can give patients supervised structured exercise for a long period of time. This was a 9-month trial, and these data showed that patients actually stuck to it, they improved on it, and improved their quality of life and fatigue. So how long do we give the intervention for? And if it's successful, do we withdraw it, or do we have to continue it for long-term safety? So these are all aspects to consider with trial design. I think there's also the practical considerations. What is the duration, the route, and the type of intervention? So we want broad recruitment and inclusion criteria, but on the balance of not having too many other factors that could affect outcomes. Cachexia trials, generally speaking, I think are not that highly regarded by oncologists. So there's a hierarchy here that clinical trials, are less, cachexia clinical trials are less important than systemic cancer therapy trials. And maybe that's something we need to think about challenging. When you're recruiting to a trial, do you want a small number of centres, but having really good oversight of the patients they're putting into trials? Or does that not help with recruitment? You need lots of centres. So again, in the Pronsegramab trial, they had, I think 80 centres to recruit 170 patients to get the numbers in. There's been less interest in pharma and nutrition than there would be in other disease areas. There's been a lack of combination therapies. And I think there's a regulatory anxiety about potentially, if a drug is developed and it's successful, the cost for that if it becomes beneficial to an awful lot of patients. But also, I wonder sometimes there's a general lack of interest in this area, and that's something we are trying to improve through all these meetings and encourage people to understand that cachexia is something that affects a lot of our patients and affects the ability to give cancer therapies optimally. There's also statistical considerations. How big is the trial going to be? These are just 2 examples of some plots we've done on some endpoint work. The first one is at one of our reviews that we did looking at body composition measures. And you can see here, the bigger the dot is the bigger the size of the trial. And if the dot's coloured in completely, then that's a significant finding. So in our body composition analysis, you'll see that most trials were done of pharmacological interventions assessing measures such as lean body mass, body fat, and levels with statistical significance. So there's a clear pattern there in body composition, cachexia trials, pharmacological interventions, and specific measures really being used. The chart below looks at our oncology endpoints review, which is this is unpublished data, but there's quite a large disparity here. No one's really clear what these measures should be, when they should be used in terms of different settings, and some studies are generally not being powered for these type of endpoints, whereas they often have. So if you're going to think about an oncology endpoint, you have to think about your sample size of your trial to look at that, and really, is it a big aim to have a survival endpoint like a cachexia trial? Potentially, yes. But then I'll move on to outcome measures. So how do we really assess outcome measures of trials? Well, there's a lot of ways we can do this. But I said before, it's really some objective measures, but also how patients feel and how they function. And for what is interesting at the FDA, they do regard symptomatic improvement as a clinical benefit. And they are happy to have drugs that use physical signs or patient symptoms as their endpoints. And they also say that symptom improvement or palliation is a good measure of is a potential measure as well of outcomes. So I'm just moving on the next slide. So we've done some endpoint work, which I'm not going to go into in a lot of detail. These are all the people that took part in it. So it was a huge amount of work. And we've published 5 of these so far. And these are in the JCSM under open access. But we did different reviews on different endpoints. And you can look at these at your leisure and covering all the things. And these might give you some guidance as to what's been used in the past, what might work. And we're working together on some form of consensus statement on what we think could be useful in the future, so that we'd have trials that are being designed with similar type of eligibility and endpoint criteria. So as I say, I'll not go into these in detail, but you can look at them at your leisure if you want. Sorry, I've covered that one. I've covered up, my apologies. The other thing I just would mention is that it was challenging when we looked at different endpoints is to see how they related to other. So, for example, you would expect, studies where if you got somebody to eat more, their weight would increase. So in one of our reviews, in 56 of the 64 studies, appetite and weight were assessed. There's only changes in one of the outcomes in 30%. So really, the studies, some improve appetite but not weight, and some improve weight but not appetite. How do we disentangle these things in studies? Some studies measure weight but didn't measure dietary intake, and these didn't happen in the same way. Only 6 out of 80 trials measure both dietary intake and appetite. So it's fair to look at endpoints in isolation, but we also have to think about how they interact with each other. There's a lot we don't know. So what's the ideal cachexia trial? Well, this is getting close to that, I think. This is the Pronsegramab trial published recently. Phase 2 trial, four-arm study, placebo versus 3 different doses of this GDF15 antibody. Now, what was quite nice about this was they did preclinical work, and the preclinical work from this study seemed to move into clinic and work. They took a biomarker-driven approach, so they took patients with raised GDF15, they tried to find the optimal dose, and they picked, I would say, meaningful endpoints with clinically significant results. So people who had the drug seemed to improve appetite, improve weight, improve physical activity. So to reasonable levels. This is a very important study, and these findings are very encouraging for the future, and we'll wait for future phase 3 trials in this area. But there's also some challenges here. Does this adapt to various clinical settings? If we're thinking now that systemic inflammation is a key sort of a cornerstone of cachexia, well, a lot of patients in this study weren't systemically inflamed based on, say, C-reactive protein. So, we have to think about our eligibility criteria well. There's also, this was one drug targeting one pathway. I don't believe that cachexia is going to be fixed by one pathway. I think it's probably multiple pathways, and there's lots of other drugs being assessed out there. So we have to think, this is probably not going to be a magic bullet, but it's probably an important step in our cancer cachexia armamentarium. And also, in this trial, it wasn't clear what the background standard of care was, and maybe to give our drugs the best chance of benefit, we need to give people good background or optimal cachexia care. We need to characterize our patients better, so we understand the different subtypes of cachexia there is, and there's work. We are undertaking work on this, as are others, I know, as part of the CAN group. And also how the cancer therapy interacts with the tumour, interacts with cachexia, interacts with comorbidities, and interacts with cultural aspects. These animal trials in Japan seem to have maybe better effects than they might have done in a Western European or North American population. So, latent advertising is that we have set up in the Cancer Cachexia Society a clinical trials advisory board. The aim of this group is to help people, give them peer advice on how they might optimize their trials, protocols to meet their targets, I guess. So we've set this up, and what we would do as part of this CTAB group is we would provide a confidential, comprehensive review process for people who submit protocols. And we'll look at both phase 1 trial right through to phase 4, observational studies and PhD proposals. We do this confidentially, and we bring in people who are experts in the area if we need it for specific subject matters. It's all done, as I say, confidentially, and we would let you know of our thoughts after that, and we do not publish that. Now, you can do with that information what you want, whether it can support a grant application or whether it might help you refine your protocol, etc. This is something we've set up, and it's not for applicants who are investigators, so non-pharmaceutical companies. It's completely free of charge. So I would emphasize and urge any people out there who have got a trial in mind, please go to our website. There's a form that you complete which has some specific questions, and we would give you some confidential and fairly rapid peer review on your proposal. And it includes, as I say, all types of clinical trials. The process, if you wanted to do it initially, would be a sort of pre-application, so a sort of informal email to us saying what you're thinking about, and then we would do a full application, which is just 2 sides of A4. It's relatively short. So that's all on the website. And as I say, urge you to look at that. We're doing all of this, however, for patients, and I'm part of this group with the cancer support community. And what strikes me is that for a long time, we've, as Cachexia researchers, have tried to tell patients, I've tried to tell regulators what we think is most important for patients with cachexia. And this is taken another way. This is saying, actually, we're asking people with cachexia what helps, what matters to them. And I actually think it's this, Teresa Cahill from the FDA, they want to hear from patients. So we need to hear from patients what they think is important for trials. This is this Voice of the Patient report, which was done in 2021. I'd urge you to go and read this. This tells real lived experience of what cachexia likes and the things that matter to patients, not the things that matter to our researchers. And we do need to get over to thinking about our endpoints to things that are clinically, that are meaningful for our patients, not for regulators. So these are some of the things we use: the hand grip strength, the short physical performance battery, actigraphy, monitors on wrists, etc. And these other quality of life tools, etc. Well, yeah, that's what we use in the research setting. Maybe we need to go over and move on to different types of things. Patients, well, they need to be able to climbing stairs. Well, that allows them maybe to go to their bedroom at night or to go to the bathroom. Activity, well, that allows them to do their housework or to go to the shops, play with their grandchildren, or do other things such as walking their dog. So thinking about how we have measures that are meaningful for patients as well as potentially meaningful for regulators, and we're not there yet. It's got to be a dialogue. We need to listen to patients because they are the experts in their disease, and they will help us make our trials better. And that'll really be an iterative process with clinicians and trialists and regulatory authorities to make patient-centered, scientifically rigorous drug development. And we're getting there, but we're not there yet. That dialogue still needs to be worked on. So I'm going to stop there. Thanks very much for attention. These are my email details and Twitter, etc. And yeah, I'm happy to take any questions.
Fantastic talk, Barry, as always. Thanks very much for that. We have a couple of questions in the Q&A section. First one is from Jerome Derksen, and he's asking, did the figures and statistical considerations originate in a systematic review? And if so, can you provide the DOI? Do you have that to hand, Barry? Or
yeah, so I don't know the DOIs obviously, but they're all in the Journal of Cachexia, Sarcopenia muscle, and they have a lot of information on the trials that were done and the sample sizes for these trials.
Sure.
Most of the trials, Ross, most of them are powered. A lot of them are powered for primary endpoints, but not powered for secondary endpoints or exploratory objectives. So, which is fairly standard, but it's difficult then for us to say, well, a trial, for example, was for survival endpoint. If it wasn't powered for that and it didn't improve survival, you can't really say that it wasn't successful. It wasn't the right trial. Trial didn't ask the right question.
Sure, absolutely. And from Miles Cameron, another excellent question, saying it's an excellent talk. And given the trials have indeed demonstrated improvements in lean body mass, but little change in existing functional measures, what are the thoughts on new functional endpoints, pulmonary function, etc. A very interesting question that I would be interested to know the answer to as well.
I certainly have a bash. One of the challenges is I don't think that, we've published in that, I don't think that the relationship between lean mass and function is a linear one. So I suspect there's a lot of lean mass has to drop before function starts to deteriorate. Taking that conversely, I think function has to improve a lot before muscle mass increases as well. So we don't really understand that relationship very well. Could we go into functional tests like pulmonary function tests? Well, I guess we could. What I think I'm going back to is, are they meaningful for patients, and how do we take away this other background noise with that? So, so the stair climb test, that's a great example. So the idea would be that measures quadricep power, measures somebody's ability to get off a chair, climb into a bath or whatever. But actually, somebody's ability to climb a set of stairs could be influenced by osteoarthritis of the hip. It could be influenced by anemia, which is causing breathlessness, cardiac dysfunction, chronic obstructive airways disease. So these are they're not terribly sensitive measures. And then interestingly, in one of our reviews, hand grip strength can seem to be the most studied and the most commonly statistically significant in the studies published. So I sort of changed my mind a bit on hand grip strength and how useful it might be.
Excellent, thank you. A wee question from Prof. Zimmers. Could you expand upon the idea of overall survival as a potential endpoint in cachexia trials? Should we expect that anti-cachexia therapies should improve survival in all cancers or in some cancers?
Great question. I think at the moment it's quite a long way off as a name. We've not yet published we've done a specific review on oncology endpoints, and survival being one of them. And none of the trials were even close to being powered to detect statistics of survival. At the moment, my feeling would be that survival is still a big difference, a big thing to aim for. What I think might be more achievable might be, I'm going to use the term efficiency of cancer therapy. So with people who, if we treat their cachexia, do they have less dose reductions when they're going through their treatment, potentially less toxicity from their treatment, potentially less treatment delays, and I think that may be something quite interesting to look at. I think that may be slightly lower hanging fruit in the first instance, before we get to survival, of course. But we'd love to see a survival advantage in these trials.
Absolutely, wouldn't we? I find another question from Felix Richter. How much are other therapeutic effects against the underlying tumor taken into account when looking at cachexia trials? What about overall survival periods?
That's a really good question as well. I mean,
very insightful.
You can't disentangle it really, because if they're not on systemic therapies, they're generally too sick. So you really want to put people in these trials who are on systemic therapies, because that's ultimately where I see us using them. But there's a really nice paper published by one of the Canadian groups looking at the changes in fat mass and lean mass in patients with pancreatic cancer undergoing either gemcitabine or FOLFIRINOX treatment. And it's quite dramatic. These two different but common regimes influence fat and muscle differently. And that's one of the first papers, to my knowledge, that's tried to disentangle that. So when we're doing a trial of, say, an immunotherapy agent, we're doing a trial of a cachexia drug when we're also doing it on a background of somebody receiving immunotherapy agent like pembrolizumab. We also have to understand how that pembrolizumab might actually affect some of the parameters that we're measuring in terms of cachexia endpoints.
Excellent. Thank you. And just one last question in the chat, but we have a bit more time, so feel free to add some more. Oh, excellent. There we are. What is the FDA and EMEA acceptable primary endpoint for a registrational trial? Body weight or lean mass?
At the moment, they want really improvements in they wanted improvements in lean mass and a functional measure. So that's what they've always sort of they've wanted to do. Could we get around to using body weight? Potentially, yes. That's something that's, I think, in dialogue at the moment. And a lot of companies are going to the EMA and the FDA saying to them, what would you accept? So before they start a trial, they're asking them these questions. At the moment, I would say that they're looking for lean mass, but body weight is essentially secondary. But that could change. But they want functional measures. It's form, function, and feeling is what they're looking for. And the patient's quality of life, I think, is definitely moving up the hierarchy of what might be an acceptable primary endpoint in a cachexia trial.
Excellent. Thanks very much. Another question from Prof. Zimmer is, what are your thoughts on the appropriate endpoints for children and adolescents in cancer cachexia trials?
Oh, that's a really good question. I don't know is the honest answer to that. I think they have different types of cancers and quite often neurodegenerative type diseases as well. But I think for something like that, you'd almost want to look for a measure that was their day-to-day function and ability to almost enjoy their childhood and adolescence. So something that was very, I guess, person focused in that group would be key. Certainly not measuring, stair climb or hand grip strength, which is probably going to be quite high anyway.
Sure. Okay.
I think there's a couple more, Ross. I'm looking at them as well here. There's a couple more.
They probably just appeared, Barry. It's just been a little bit slow on my end.
I can see there's one, I think, No, I think actually you've got them all, Ross. I think we have actually covered them all.
So I have a quick question, if that's okay, and I think it's a very insightful point that you made at the end about measuring endpoints that essentially patients actually care about, and because in many ways we don't do that. And do you think of any strategies that we can employ to perhaps increase that applicability to patient care? I'm thinking more about involvement of patients in trial design and perhaps the acceptance of drug authorities that this is an acceptable endpoint pre completion of a trial. Is there any views that you have on that?
So I think absolutely. I think that a lot of trials now have patients involved in the development of them, but also certainly in investigator-led studies that we do, having patient and public involvement is mandatory for these trials. So I think it's key. What I'd also like to see though is more mixed method type approaches. So studies, numbers are all well and good, but having the experience of qualitative data for patients who've taken part in some studies. So it's all very well a study showing that an exercise regime, helped them. But if you actually had interviews or focus groups with people in the trials who actually could add some, use the term meat on the bone for this, then I think that would be really helpful. And this gives it more of a face than just being a sort of a faceless clinical trial.
Yeah, absolutely agree. Just another wee question. I think we can certainly help with this. Is could we put the slides for the presentation up for a period of time to let us write down some of the numbers, sources, citations, etc. And I think it's something we can certainly manage for the group. I think that's completely reasonable. Just another slight question from me, Barry, and it touches a wee bit on the question that Prof. Zimmer's asked about different patient cohorts. How much do you think we have to learn from trials or indeed studies looking at cachexia, which is not related to cancer, perhaps in the vascular or in the neurodegenerative sphere? Do you have any insight into that?
Yeah, I think we've worked a wee bit too much in silos with that, Ross. I think it's a good point. The one that I'm sort of particularly mindful of is the work in COPD, chronic obstructive airways disease. They're probably ahead of us in terms of the multimodal sort of complex interventions. So there's certainly a lot to be learned from, working with these other groups, and also looking at, thinking about things like cardiac failure. That's a cachexia syndrome essentially, and we're not really looking at these other factors. A lot of our patients will also have existing disease. So somebody with lung cancer is likely to have, a degree of maybe chronic airways disease, cardiovascular disease, and we can't separate this. So we have to really do some sort of, again, real life applied research to see how these things all potentially impact our outcomes. It's all very well having a very clean trial, but the real world's not clean in terms of, the clinical setting. So, more pragmatic design, I think, is quite important.
Absolutely. I mean, and we saw quite a bit of work, similarities and differences between vascular patients and cancer patients in Glasgow. So that's an interesting insight. Jay Bone has just asked, do you envisage a broad label for cancer cachexia being possible across, very insightful here, across indications, or do we need to run phase 3s in individual cancers due to different standards of care and combination therapies?
That's a great question. So I think what will happen is we'll run the phase 3s in 1 or 2 cancer types, but if these drugs are successful, I think that people will start to use them off label, off indication. Certainly, in my field of palliative medicine, most of the drugs we use are unlicensed and off label. And if a drug's good in one condition, it generally is good in another. So I think that we'll do these trials in a couple of big conditions like lung cancer or pancreatic cancer, but people will use them in other cancer types. Now, that comes challenges, I guess, in countries where reimbursement's an issue, but I generally think that it's a lot of money to run a phase 2, never mind a phase 3 trial. And if you do it in too many groups at once, there's just too much background noise. What you ideally want to do is maybe do a couple of groups of cancers where there's similar types of therapies, to immunotherapy.
Yeah, absolutely. I think once a treatment's out there, one cancer type, it inevitably is used in others. It's just what happens. Excellent. A very insightful question from Jay there. It's fantastic. I don't personally have any other questions, Barry. Anouk, do you have anything you want to ask, Professor?
I see.
Sorry,
Oh,
please.
sorry. I see one more question in the chat that we
fantastic.
might want to address. It's about GDF15, which is a promising antibody, but we don't have, but we have to be ready for possible resistance towards the therapy. And what is your thought for targeting RET, which is downstream of GDF15?
Yeah, so I'm not aware of that specific aspect you mentioned, Dr. Catry, but what I did say earlier was that I think that the GDF15 pathway is not, I don't think it's going to be the magic bullet. Could be an important part of the armamentarium, but I suspect there are multiple targets. I think what the GDF15 trial does is engender a degree of optimism and excitement around this area, that trials are possible, trials appear to be successful and have clinically meaningful endpoint for patients. So I see this trial really as a prototype and something we should look on as a real call to arms to encourage us to keep going. But there's lots of other trials that are going on at the moment. And at the moment, it's just a phase 2 trial. At the start of the talk, I showed a lot of phase 2 trials that didn't get to phase 3. I showed phase 3s that didn't get approval. So time will tell, but I'm optimistic about the ponsegromab work at the moment. It looks excellent.
Absolutely. Another quite insightful question. We'll need to wrap up fairly soon, I believe, but I think we should answer these two certainly. What about preventive cachexia trials? Are there any trials going on in this direction, basically prior to the cachexia diagnosis? An interesting early intervention question there.
Right. So I guess yeah, yes and no. We've done the MENAC trial. We tried to really do that as a preventative study. We didn't take people who had lost weight as an eligibility criteria. We took people who were newly diagnosed with lung or pancreatic cancer, and on the basis that they were going to get cachexia if they didn't have it. So I think prevention is key. Ideally, we don't wait for people to have myocardial infarctions before giving them a statin. We want to assess for high levels of cholesterol and then prevent, these things happening. So I think the real aim is to have drugs to prevent or attenuate/slow down cachexia progression. That's what we want to. I do feel that once cachexia is there, the ship has it's certainly, it's left the port, might not be on open sea, but it's certainly, it's going. So we want to try and prevent it, I think. So I think that's a great concept as well.
And I suppose that's what multimodal interventions are. If we can prevent further decline, that would be the aim. And a really nice, I think we'll have to take this as the final question unless I'm incorrect about that. 'Cause, thanks for a wonderful talk. It's a dry question, she says, but I don't think it is. Weight loss precision. How is weight loss precision handled in studies that use body weight? For example, if losing 2% of body weight is a criteria, how do you ensure the lack of confounding factors such as edema, ascites, or simple errors in measurement? I think it's an important mechanistic question that.
A big change that's happened in the last couple of decades really is that our ways of assessing body composition have improved dramatically. So we do DEXA, which allows us to assess body weight, but body water, but we also do CT-based body composition, which allows us to get a better measurement to assess if these other factors, are present or not. And recently, traditionally we'd have used a sort of single slice level and extrapolated that to give a whole body estimation, but now we're doing whole body composition analysis. So we're managing it by doing better assessment of body composition parameters. Sarah, thanks.
Certainly, excellent answer there. And a thank you from Sarah. There you go. Okay, that's us just past 6 o'clock. If there are no further questions, then I think we'll wrap this up. A fantastic talk from Barry, really insightful and a lot to think about with trial design moving forward. And I would encourage you to attend our next seminar, which will be in December. If there aren't any further questions or any further issues, I think we'll call it a night just now.
Thank you.
Take care.